This is going to be a brief introduction to evidence-based veterinary medicine. I want to talk a little bit about what evidence-based veterinary medicine is, and also why it's important, why it's a useful tool that we as veterinarians should adopt more widely. Clearly, this is an enormous subject, and I can only cover briefly the philosophy and the methods of evidence-based medicine, but hopefully this will be a useful introduction for people who are not especially familiar with this subject. Evidence-based veterinary medicine is predicated on many of the same principles and employs many of the same techniques as evidence-based medicine in the human domain. Evidence-based medicine is a much more fully developed and implemented approach in human medicine, and veterinary medicine is at an earlier stage of developing and implementing this practice. So many of the principles of evidence-based veterinary medicine and the definitions that we use of it are drawn from the human field. David Sackett, one of the early figures in the development of evidence-based medicine in the human field, gave this definition. Evidence-based medicine is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. He then went on to say that it involves integrating our individual clinical expertise with the best available external systematic research evidence. And I think the key points to take from this definition are that evidence-based medicine is conscientious, which means it is a process that we need to commit ourselves to, that we need to put energy and time and effort into. It is explicit. We need to be clear with ourselves, with our colleagues, with our clients about what evidence we're using and how we're using it to generate decisions. And it is judicious. There's often, as we'll get to when we start talking at some point about misconceptions of evidence-based medicine, a tendency to think that it involves blindly following the results of or systematic research. But it is not a blind process or an automated process. Evidence-based medicine is judicious. It requires individual judgment. And it is a process that requires us to use our clinical expertise and to integrate what we know from our own experiences with what we know from systematic research. Finally, and most importantly, it is a system or an approach for making decisions about the care of individual patients. It is ultimately all about making good decisions. One addition that was made at a little bit later date to the definition commonly used in the human field for evidence-based medicine was that it involves not only integrating external research evidence and our own individual clinical expertise, but the unique values and circumstances of the patient. And in veterinary medicine, values in particular usually applies to the values of our clients. It's critical that we understand that the client plays an important role in the decision-making process. The most well-tested, highly validated intervention is of no use if it conflicts with the needs or the values or the desires of the client, because it won't be applied. And similarly, patients are all individuals, and there are differences in every situation, every set of circumstances. And part of the judicious aspect of evidence-based medicine is taking these differences into account when using research evidence to help us make decisions. This extension to the definitions that I've already discussed for understanding evidence-based veterinary medicine was provided by Drs. Cockcroft and Holmes in their Handbook of Evidence-Based Veterinary Medicine. What I like about this is that it acknowledges that evidence-based medicine is not merely a set of techniques or tools. It is an approach, and it is founded in a certain philosophical perspective. That perspective is the philosophy of science generally. So at its heart, evidence-based veterinary medicine manifests our confidence in the methodology of science, which has developed over a long period of time, several centuries, and exists in order to help us distinguish true from false, effective from ineffective, safe from unsafe, proven from unproven. Evidence-based veterinary medicine does have certain philosophical preconceptions. And if one is to apply science and evidence-based medicine to testing our clinical interventions, to understanding health and disease, one has to accept the validity and the importance of these preconceptions. The fundamental concept behind evidence-based medicine is that science works. Now, what is science intended to do? Science is a system for generating knowledge. It is an approach that allows us to investigate the natural world and learn things about it, which then give us the ability to predict and, in some cases, control things that happen in the natural world. Science is not perfect. I certainly would not suggest that scientific knowledge is infallible or unlimited. It is, like all human institutions and activities, flawed and constrained by our limitations as beings. However, I do think that one can make a strong case that science works better than any other process for generating knowledge about the natural world. Winston Churchill famously said that democracy is the worst form of government, except for all the other forms that have been tried. And I think that this principle applies equally well to science as a way of generating knowledge. It is the worst form of epistemology or knowledge generating system, except for all the others that have been tried. So, what are some of the underlying philosophical ideas behind science generally, and by extension behind evidence based veterinary medicine? Some of these may seem simple and obvious, but in other contexts, when we discuss alternatives to evidence-based medicine, we find that, in fact, there is some disagreement about some of these fundamental principles. So I think it's useful to us to examine them briefly. Realism is the principle that the natural physical world exists, and it exists independently of what people believe or know about it. Our thoughts do not meaningfully impact the physical world. Our job is not to create or alter it through our thoughts, but simply to try to discern how it is, what it does, and how it works. And empiricism is the principle that we can, in fact, do this effectively. We can develop true, useful knowledge about the world through our perceptions and through experimentation. Now, reductionism is a term that I think has gotten a bad rap. It implies ignoring the complexity of systems like organisms or ecosystems and focusing narrowly and somewhat blindly on the details, missing the forest for the trees. I think certainly reductionism can be this, but that's a very extreme form of reductionism. In the context of science and the methodology of science and evidence-based medicine, reductionism is simply a tool. One way to understand complex phenomena is to understand their components and how they interact with each other. This is an important tool for science, and if one rejects the philosophical concept that reductionism can generate useful knowledge, then one may have difficulty employing the scientific method. Methodological naturalism is a principle that is implicit in how science works, but is rarely discussed outside of the domain of philosophy and philosophy of science. And I think part of the reason for that is it does raise some potential conflicts with other culturally important values or philosophies. Methodological naturalism simply says science is a system for developing knowledge about the natural world. It is predicated on the idea that the phenomena we are studying have predictable behaviors. They obey the general laws that can be deduced about the nature of the universe, that they can be investigated through hypothesis generation, empirical testing, and validation or invalidation of hypotheses, that the scientific methods can be used on them. Supernatural phenomena generally don't meet these criteria. Often such phenomena, by definition, don't obey predictable regular laws, cannot be manipulated or investigated, and are exempt from regularity or predictability. Such things are not amenable to investigation through science. So science limits itself to the natural physical world. This can become a problem when particular medical interventions, for example, are proposed or defended on the basis of theoretical foundations that incorporate supernatural entities. Things like energy medicine, for example, that one can improve health or treat physical disease in the body by manipulating the spiritual energy of the patient. These are things that are difficult to talk about in the context of science or generate scientific evidence about, because methodological naturalism is part of science, and science simply doesn't have the ability to investigate these things. And then finally, scientific skepticism. Skepticism is a term which also has gotten a bad rap. It does not mean the automatic rejection or negation of ideas. It means that ideas or claims made about the world should present evidence in their defense before they are accepted. And scientific skepticism simply means that when you make claims to knowledge about the world, you should be expected to produce scientific evidence in order to justify those claims. Evidence-based veterinary medicine is also, in addition to being an approach or a philosophy founded in the philosophy of science, a series of steps or actions that one as a clinician or a researcher can take. And as a practicing veterinarian in the clinic, this is a series of steps that I think embody the process of evidence-based medicine in general. The first, of course, is to ask a question, and ask a specific question. Since evidence-based medicine is a process of generating decisions by using knowledge gained from science, in order to employ evidence-based medicine, I have to start with a question that can be answered to some extent using scientific information. Then I have to go out and find the relevant evidence. The next step is to say, okay, now I have a question about the world. What does science tell me? What evidence exists out there to help me answer that question? And as part of the explicit process of evidence-based medicine, I must then evaluate the quality and the limitations of that evidence. Not all evidence is created equal. Some forms of evidence are more reliable than others. And evidence-based medicine gives us a scheme for evaluating the evidence that we're using to support our clinical decisions. At the end of the day, then, I have to make a decision. I have to draw a conclusion. The whole purpose of this process is to give me useful information in order to help support clinical decision-making and patient care. And then finally, and in a step that I think is often overlooked outside of the use of evidence-based medicine as an explicit and intentional process, I have to assign a level of confidence to the conclusions or decisions that I've made. I think we all recognize on some level that our knowledge is imperfect and our decisions contain potential flaws. However, I don't think that as clinicians, as veterinarians, we often think enough about the degree of confidence that we should have in a particular conclusion or decision. And evidence-based medicine provides, again, a scheme or a mechanism for helping us determine how much confidence we can have in the decisions that we've made. Evidence-based medicine is also an iterative, ongoing process. Part of the conscientious nature of it is that we repeat the process over and over again. Within the context of a particular case, there may be separate problems and many questions we can answer. There are certainly, in the context of our practice as a whole, general questions which come up again and again. And evidence-based medicine requires us to ask all of these questions and then to revisit them because, of course, the evidence changes. So as an example, a question that you probably shouldn't ask because evidence-based medicine is not going to give you a useful answer to it is something like, does glucosamine work? What does that mean? What are we trying to use it for? What is the context? It's too broad, too general a question. And it's a question, unfortunately, that's often asked about in medical interventions in general. Well, does it work? It's not an answerable question because it's too vague. A better question would be something like, does oral glucosamine reduce the pain associated with naturally occurring osteoarthritis in adult dogs more than does a placebo or a non-steroidal anti-inflammatory like carprofen? In other words, we want to ask very specific questions. What is the intervention? What is the disease or problem, the indication that we're using it for? What is the measure of outcome we're interested in? What is the population that we're interested in, because dogs are not cats and cats are not cows? What is the alternative to the intervention that we're using? These are all aspects of a good answerable question. And then, of course, we have to find the relevant evidence to help us answer our question. There are many different layers or levels of evidence, and I'll talk about that a bit more in a minute. But I'm going to go through from the more reliable and the more useful to the somewhat less useful and give you an example in the context of this specific question about glucosamine. So one level of evidence that is the most useful to an ordinary clinician is the systematic review. This is a review in which specific questions have been asked, evidence has been identified, evaluated for quality, appraised critically, and then summarized by someone else. And that gives us answers to our questions that are pretty reliable, or that at least have clear rationales behind them. So in this case, there's a systematic review of the efficacy of nutraceuticals to alleviate clinical signs of osteoarthritis. And one of the nutraceuticals evaluated in this report was glucosamine. So I could go to this report and I could get some pretty solid, detailed, explicit information about the question that I've asked. Does glucosamine help more than placebo or carprofen to alleviate pain with arthritis in dogs? A similar kind of evidence, but one that's a bit less precise and formally generated, is the critically appraised topic. And there are lots of names for these. But critically appraised topics are brief reviews of usually fairly narrow, small questions that do not purport to be a comprehensive search of the literature, or that do not necessarily evaluate all the pieces of evidence available in detail, but they do explicitly ask very narrow questions and at least provide some information about the level and quality of the evidence found in order to answer those questions, and about the limitations of that. There are a number of resources that one can go to find critically appraised topics, and this is a growing area in evidence-based veterinary medicine. Best Bets for Vets is a website which provides, at the moment, a small number of critically appraised topics, but that number is growing all the time. This is a project put together by the Center for Evidence-Based Veterinary Medicine at the University of Nottingham. And they have a critically appraised topic on nutraceuticals versus carprofen in dogs with arthritis. So this would be useful information to help in making a decision about what to recommend for a patient, for example. Banfield also has a number of critically appraised topics, white papers, they call them also, and glucosamine is certainly one of the things that's been evaluated, but there are many, many others. These are efficient, useful shortcuts for veterinarians in practice that employ the evidence-based veterinary medicine process, but help to save us some of the work that's involved. Now, specific clinical trials are, of course, useful evidence, and perhaps are better known sometimes than the pre-appraised kinds of evidence you find in systematic reviews or in cats. However, in order to make good use of clinical trial data, we have to do a bit more work. We have to look at the trial, the methodology, the potential sources of bias, and come up with some conclusions about whether or not the author's opinion about what the evidence says is really what we think the evidence says. Unfortunately, having been published in a scientific journal does not guarantee that a study is properly done, or that the conclusions presented in the abstract and the discussion accurately or fairly represent the data. So this is a clinical trial looking at glucosamine versus carprofen and some other things in the treatment of arthritis. It's definitely useful information, but unfortunately there's a tendency for veterinarians in practice to read the beginning and the end of these things, the abstract and the discussion, and then draw a conclusion and go and implement that without recognizing that there's a lot of potential bias and other sorts of errors that can come into individual clinical trials, and they're less useful as evidence than an overview of the research in a particular subject. And then there's a whole bunch of other things which we can use, but which proceeding down the list become less and less reliable. Obviously, we extrapolate dramatically and frequently from human clinical trials, and there's some utility to that. We would be hard-pressed to make decisions without making some use of that evidence, because it is so much better quality and quantity than what we have in veterinary medicine. But it does involve some risk, extrapolating from one species to another, and from the context of human medicine, which is very different than the context of veterinary medicine. Narrative reviews, unlike systematic reviews, narrative reviews are essentially one person simply looks at the literature and decides what they think it means and summarizes that. Useful, absolutely, but with more potential bias than a systematic review, which contains very explicit mechanisms for identifying potential sources of bias. Consensus statements, this is usually a bunch of smart people sitting around in a room and deciding as a group what they think the evidence means. Also very useful, very convenient, but subject to some limitations. In vitro and lab animal research can provide information about the likelihood that a therapy is useful in clinical practice. They certainly can't prove that actual use of that therapy in patients in the real world is a good idea. There are lots of things that look promising in the lab but don't turn out to work very effectively or safely in the clinic, but it's useful evidence. Pathophysiological rationale, we basically understand how a system works, so we can extrapolate from the general understanding of that system to making specific decisions about what to do for a particular patient. Useful, but quite dangerous, because there's always some little fact or little bit of information that we don't have that makes our ultimate conclusion false, even if our reasoning is sound. Clinical use or our personal experiences, well, I tried it and it seemed like it worked, or I tried it and I didn't like what happened, not very reliable. And than anything and everything else. I've seen people make decisions about when to perform surgery on the basis of the alignment of the stars, and there are all sorts of forms of evidence. The reason I include these things is simply to point out that this hierarchy can go from flawed and limited but pretty reliable down to completely ridiculous, and we have to be aware of what level of evidence we're using. Perhaps the most persuasive evidence for most people is somewhere near the bottom, is the individual experience of a particular patient or doctor. And that is near the bottom because it is among the least reliable forms of evidence available. This hierarchy of evidence pyramid is one of many versions of this that will appear throughout the literature on evidence-based medicine, and it simply reiterates what I'm saying, that the systematic review and critically appraised topics are fairly reliable forms of evidence because they go through the trouble of explicitly identifying limitations and sources of bias. You get down to the bottom and you're talking about people's opinions, and that's a lot less reliable. The quality of evidence is something which, again, is difficult for most of us in practice to have the time or expertise to assess in detail, and that's why pre-appraised evidence like systematic reviews are so helpful. But it's important to recognize that not only are randomized controlled trials better evidence than, say, anecdotes or case reports, but that the quality of each of these kinds of evidence makes a difference. You can have a terribly performed, poorly controlled randomized clinical trial with lots of built-in bias that ultimately doesn't mean anything useful. Or you can have an excellently done retrospective study, which is much more useful and more reliable in guiding clinical decision making. So at some point, evaluating not only the level of evidence you're talking about, but the quality of evidence is really important. This is a scheme for evaluating the quality of particular kinds of evidence and generating a grade, if you will, good, fair, or poor. And a good systematic review or consensus statement or guideline will have this built into it so that you can see whether or not the particular pieces of evidence used can be trusted and to what extent. So overall, when I'm talking about evidence appraisal or judging the limitations of the evidence that you're using to help support your decisions, these are the principles I'm talking about. High-level evidence is obviously better than low-level evidence. You're going to trust a systematic review or a CAT to a greater extent than you're going to trust a single case report or an anecdote. High-quality evidence is obviously better than low-quality evidence. If you have a clinical trial that is open label and not randomized and had a high dropout rate and generally missed a lot of major methodological markers there to indicate that the risk of bias is low, then you're probably going to be pretty skeptical of that trial result or conclusion. Whereas if you have a really well-done trial that does a good job of accounting for potential sources of bias, that's going to be more reliable, more useful evidence. Interestingly, negative evidence is often more reliable than positive evidence, which is unfortunate because negative evidence is less appealing to everyone and is subsequently not published as readily. But if you think about it, most of the biases built into how we study things and into the trials we design are biases in favor of confirming what we already believe to be true. We rarely set up a study in order to prove that we're wrong, but we set up a study to prove that a particular relationship that we believe exists actually holds. And that means that if we do that and we come to the conclusion through the data that that relationship is not true, that our hypothesis is false, that is more reliable because our biases would likely have driven us in the other direction. Now, there are exceptions to this. Sometimes replication trials are set up specifically to disprove someone else's hypothesis, and then there may be a negative bias. But in general, in veterinary medicine, that's pretty rare. We don't do very many replication trials, unfortunately. So most of our studies are done by people with a hypothesis in order to support that hypothesis and in some ways, perhaps promote the reputation or career of the person who's doing that. Or they are studies put together by companies in order to provide evidence to support the marketing of a product that they're selling. Positive bias is always going to be more of a problem in these kinds of studies, so negative results are perhaps more trustworthy and more useful. In any case, no single study is ever definitive evidence. There's a well-known phenomenon in human medicine called the decline effect, where the first studies on a particular intervention show incredibly huge effect sizes, and then as more studies are done, as we get a better handle on the sources of bias having to do with that particular problem, and as people with competing hypotheses begin to get into the business of investigating that intervention, the effect size diminishes until it either goes away entirely or we achieve what is probably the real effect of that intervention. What that means is individual studies will always vary in their conclusions and in their quality. And so we can never rely on one particular study to have high level of confidence in a particular conclusion. Now, in veterinary medicine, the sad fact is sometimes one study is all we have, and we certainly must use the evidence we have, not the evidence we wish we had, to help us make decisions. But it's important to remember that no single study is ever definitive. And then finally, when you're talking about evidence appraisal as a clinician, the best thing to do is get someone else to do it for you, to make use of critically appraised topics or systematic reviews, because few of us have the time or the expertise to do really good quality critical appraisal. And then finally, what's the most important step in this whole process? Draw a conclusion. This is the point at which you have to make a decision. So you've looked at the evidence, you've considered it in light of the particular circumstances of your patient, the values and goals of your client, your own experiences, your resources and skills, and then you make a decision. And then you assess the uncertainty of your conclusions. This is critical. This is very important for us to not get caught up in perpetuating ineffective practices and to not oversell things to our clients. It's very important for us to make an explicit assessment for ourselves and for our colleagues and for our clients of uncertainty. This is just one system that was used in a particularly helpful systematic review process for assessing uncertainty. Is the benefit greater than the risk? Well, then you should do it. It's something recommended. Is the benefit maybe a little bit greater than the risk? Well, it's reasonable to do that. Does the evidence suggest that the benefit and the risk are about the same? Well, hard to know. Might want to do it, might not. Depends on the circumstances. Is the risk clearly greater than the benefit? Well, then obviously you shouldn't use that intervention. These are very straightforward, practical ways of assessing your confidence in your conclusions based on what we've already done, which is a good, careful appraisal of the quality of the evidence. You have to decide, do you want to take a leap? Do you want to try this therapy? Do you want to use this test? Or do you want to maybe just be very cautious in whether or not you implement it? Assessing uncertainty is useful in guiding clinical behavior. Okay, so that's evidence-based medicine in a nutshell. It's certainly a very brief and limited evaluation, and lots of things have been left out, especially the details of these processes. But hopefully that gives you a general sense of what evidence-based veterinary medicine is. So now we need to talk about, why do we need it? Why is it useful? Well, there are several things that evidence-based veterinary medicine can help us with. One, as I mentioned, it is an outgrowth of the scientific process for generating knowledge. So evidence-based veterinary medicine helps us to know what works and what doesn't work, to help us know which therapies are useful for which patients and which problems under which circumstances. It gets into the details and helps us make better clinical decisions. So better information means better decisions. Better information management is also one of the goals of evidence-based veterinary medicine, and we'll talk a little bit about what that means. There's a tremendous amount of information that veterinarians have to consider and incorporate into their decision-making processes. And evidence-based veterinary medicine is not only a process for generating evidence and knowledge, it's a process for helping us manage and use knowledge more efficiently. And informed consent. The explicitness of evidence-based veterinary medicine is really important in helping us to be clear with our clients about what we're offering them, what the uncertainties are, what the confidence we and they should have in our recommendations is. It involves better information not only for us, but for our clients, which then gives them a better opportunity to exercise informed consent. And of course, ultimately, what's it all about? It's all about better outcomes, better patient care. So why is it that this system is useful and helpful? Well, frankly, because we're easy to fool. Human beings have a system for understanding the world, a set of perceptual systems, a set of cognitive systems, and we know a lot about those systems. Psychology and neurobiology has developed a tremendous amount of information about how humans' brains work and how we make decisions. And one of the inescapable conclusions that has come from that information and also from the history of medicine and science is that it's easy to fool us, and we fool ourselves frequently. And so evidence-based veterinary medicine is simply an explicit, judicious, conscientious process for applying what we know about the limitations of human perception and reasoning to helping us avoid error in medicine. Dr. Mark Crislip, who is an infectious disease specialist and who writes often on these topics, I think put it quite well. Often getting the right diagnosis and therapy is less about what you know and more about being rigorous about understanding how you know, understanding your own processes for using knowledge and making decisions. Only when you are conscious of your ability to think poorly can you compensate. Science and evidence-based medicine at their heart are compensatory mechanisms for helping to fix the flaws or fallibilities in our reasoning and our decision-making processes. But we need to know what those are and accept them before we can make use of those tools. For those of you old enough to remember this book, a more general statement of this is the purpose of the scientific method is to make sure that nature hasn't misled you into thinking you know something you actually don't know. And nature misleads us because we are easily misled. There are all sorts of cognitive biases, specific quirks, heuristics, things that happen in our brain that lead us to misinterpret and misunderstand things. And this is a subject for another day, but the literature in cognitive psychology is quite explicit. And unfortunately, in veterinary medicine, we've made insufficient use so far of what we've learned about how our own brains and decision-making processes work in order to help us avoid error. That's beginning to happen more in human medicine, and it is part of what evidence-based veterinary medicine is about, making use of what we know about how we make mistakes to help us make fewer mistakes. Bottom line again is that science, which is a process for generating knowledge that compensates for these kinds of limitations and errors, works. And it works in any context, in any culture, in any situation, better than anything else we've come up with before. So what's some evidence for that? Well, this is a graph looking at human life expectancy in the last 10 or so thousand years. Now, clearly, for much of this time, the data is very poor quality and the evidence is not very reliable. So I don't mean to imply that the specific details of how long people have lived on average over this period of time are reliable. What I can say is that there is good reason to think from the very beginnings of human existence up through the historical period, the evidence is pretty clear that this pattern has been consistent. That for most of our existence as a species, there has been very little change in how long we live or in other markers of health and well-being, such as infant mortality, for example. And in the very recent past, there has been a dramatic change in these markers of health and length of life. And it's not like we haven't been trying. As far back as you can go in the archaeological record, there is evidence to suggest that people have been trying to manipulate their health to promote and preserve health and to fight disease. And in every culture looked at so far, folk medicine, methods for manipulating the world in order to keep us healthy or to treat our diseases exists. And there are great similarities in how that folk medicine works. What the evidence does not suggest is that it's been very effective. That in general, unsystematic, traditional methods of generating knowledge about health and disease have not changed objective measures of human health very much throughout history. And when you get into the historical period and you start looking at specific approaches to health and disease, specific sets of theories and interventions which still exist today, you see the same pattern. Ayurveda is a system for understanding health and a set of tools, including a lot of herbal therapies and manual therapies for improving health, which evolved in India and has some connection to the ancient Greek methods and to Chinese methods as well. And it's been around for several thousand years. There's no evidence in the historical record that it has significantly improved the length or quality of human life in those cultures in which it's been employed. The same is true for traditional Chinese medicine, which is a bit of a misnomer, but the most famous intervention involved in that system is acupuncture. This is also a complete system for understanding health and disease and manipulating it. There's a lot of debate about exactly when acupuncture as we understand it today developed. But it is, again, clear that it's been around for a very long time and that it hasn't had a measurably significant impact on health and longevity. And I certainly don't intend to pick on any particular culture. Humoral medicine is the traditional folk system for understanding medicine that developed in the West, in ancient Greece. And it has very many similarities and quite plausibly specific historical connections to both Ayurveda and Chinese traditional folk medicine. But humoral medicine was the system of thought that led to bloodletting and purging and cupping and leeches and all of the things that are famous from Western pre-scientific medicine. And it is a system that was widely believed to be true and safe and effective for thousands of years by the best and brightest minds in medicine. Nevertheless, good, fairly reliable historical evidence suggests that, in fact, it was not safe and effective. And then there's this thing called science. Somewhere in the 1500s, people started looking at the flaws in human perception and reasoning and developing mechanisms for trying to compensate for those. And those have gradually over time turned into the system of science that we currently have and which is continuing to evolve. In parallel with this, there has been an unprecedented change in human life expectancy and in other markers of human health, such as infant mortality, perinatal mortality of women. And in cultures in which science is not available as a healthcare tool or as a tool for improving sanitation, nutrition, many things besides healthcare that science has helped us to improve, the pattern of life expectancy and infant mortality and such things seen throughout history continues to exist. And in cultures which have the resources to employ science as a means for generating knowledge to help us predict and manage the natural world, there's been a dramatic improvement. So I think it is fairly difficult to ignore the lesson of history that science works. Science generates knowledge that is more reliable and more useful in managing health and many other things than any other system that we have so far come along and used. To provide a little bit more evidence for that is somewhat more reliable in terms of the data, this is a comparison of age at death, population age distribution, and average life expectancy for England and Wales in two periods. 1891, which is well into the development of the scientific method, but not yet too far into the time in which science actually allowed us to develop specific technologies for improving things like sanitation and nutrition and healthcare. So where people were living very much in a pre-scientific way, even though science as a philosophy had come quite a ways. And 1966, which is a period of time after the technological revolutions brought about by science had had a little bit of time to take effect. And I think the difference in these two patterns is very clear. The first chart from 1891 illustrates what is essentially, to the best of our knowledge, been the pattern throughout human history. Most people die very young. By far the largest proportion of deaths occur in the under 4 years of age group. The population is heavily weighted towards young people because people don't get to be old very often, and the proportion of deaths that take place in the oldest age group is quite small. The average age at death is somewhere in the 30s. Getting much past 40 was unusual. There's a reason why the teeth that come in your 20s are called wisdom teeth, because you were old enough to be considered relatively wise in your 20s. That certainly doesn't seem to be the case today. The lower chart shows what is more commonly the pattern or the distribution of age and deaths in societies today which have the resources to employ the fruits of science to improve things like sanitation and nutrition and healthcare. The age distribution is much more even because most people get to be old. The number of deaths that occur in the youngest age groups is incredibly small, and most people get to be old, and so most of the deaths happen in aged people. The average life expectancy is up in the 70s, and it's continuing to go up. I think that the evidence is clear that science works. Science has done a better job of allowing us to predict and manipulate the natural world in ways that are beneficial to our health and well-being than any other system that's come before it. Now, what did we do if we don't have science? How do we make judgments, particularly in healthcare, without science? And I will use as an example of this bloodletting, because, again, that is a practice, a healthcare practice that was widely believed in and employed for thousands of years, that originated largely from the notions of ancient Greeks about different humors in the body being balanced, and many diseases were thought to be due to an excess of blood, one of the humors, and so removing extra blood was considered a viable medical therapy. And how did we come to the conclusion that this was a safe and effective therapy over time? Well, the most significant way that we made such a judgment was through individual observation and experience. A doctor or a patient would say, well, I tried therapy X and the problem went away, so therapy X must work. And that seems perfectly plausible. It is still the most common justification for virtually every medical intervention offered today. However, it is not very reliable. In the case of bloodletting, Benjamin Rush, who was a brilliant physician and one of the last staunch defenders of this practice, provides such an anecdote. Well, I bled my eldest daughter when she was 6 weeks old, and I bled one of my sons twice when he was 2 months old for fever, acute fever. And in both cases, they got better. Life appeared to be saved by this remedy, and I could come up with many more examples of this. This is a justification for a practice which we now know, through good scientific study, actually causes far more harm than benefit. It's not even a neutral therapy. It's an actively dangerous therapy. And yet, it is easily possible for individual experience to suggest that it is safe and effective when it is not. Another way that we make judgments about medical therapies in the absence of objective scientific information is by referring to history or tradition, to the judgments that our ancestors or forebears have made. Well, this therapy X has been practiced forever, and all those doctors and patients couldn't have been wrong for all those years. And that is still very persuasive. People will often justify methods such as Chinese medicine, acupuncture, Ayurveda, with the argument that these things have been around for 2,000 years, so they must work, because why would people continue to do things that didn't work? Bloodletting is a great example of something that people did, in fact, use for thousands of years, which not only didn't work, but was actively harmful. Another defense of bloodletting in the last days of the practice says essentially as much. He really thought it saying too much that we should assume to be so much wiser than our fathers, who had lent their approval to a custom sanctioned by ages of experience. Unfortunately, the collected experience of people over time is not really any more reliable than the experience of individuals in terms of deciding which therapies are safe and effective and which aren't. But this is one of the most commonly used pre-scientific methods for generating knowledge. And finally, theory or common sense, a more general version of pathophysiologic rationale, taking an understanding of how a system works, a model for nature, extrapolating from it and using that as a justification for a particular action. Since we know X is true, and Y obviously follows from X, it just makes sense to do this, right? So again, Benjamin Rush, in defending bloodletting, refers to this general theory that I mentioned before about different humors being balanced. The spleen was often found in people with febrile diseases to be enlarged, and today we have a pretty good understanding of how that works and what the spleen's role is. But in those days, the enlargement of the spleen in people who died of febrile diseases was believed to mean that the spleen was a basin intended to hold extra blood. And if you had too much blood, then the spleen got big and things got backed up or congested. And so you needed to draw more blood out of the system. And this was a rationale for draining blood from people with febrile diseases, which of course we now know in many cases to be infectious diseases. They didn't know anything about infection in the days of bloodletting. And clearly, draining blood out of people who have an immune reaction that is severe and are fighting an infectious disease is not going to help them. And in fact, the evidence subsequently proved that it reduces their likelihood of survival. But this was a perfectly consistent, coherent model of how health and disease worked, and it allowed this perfectly obvious, sensible argument to be made for why we should take blood out of these people. Exactly the same sort of rationale is still in use to justify many pre-scientific or pseudoscientific therapies. It's not like we haven't known for quite a while that the human brain is limited and that we are subject to error and to fooling ourselves. And I just wanted to kind of give you a quick collection of statements on this subject to illustrate both the idea and also how long we've known this and how clearly understood it is, and yet, unfortunately, how little we've been able to change our practices until the advent of formalized science and evidence-based medicine. Richard Feynman, a famous physicist, said, "First principle is that you must not fool yourself, and you're the easiest person to fool." And clearly, as a scientist, he understood that the value of the scientific method was in helping to compensate for this tendency to fool ourselves. A ways back in the 19th century, John Stuart Mill wrote that, unfortunately, for the good sense of mankind, the fact that we are fallible doesn't carry as much weight in our practical judgment as it does in theory. Everyone knows that they're fallible. We all understand that we're imperfect. But we rarely think it necessary to take precautions against this fallibility or to admit that any particular opinion or belief we have may be an example of how fallible we are. So if you ask someone who is making a claim that is not based on good scientific evidence, if they, as a human being, could be fallible, they will say, well, of course, I'm not perfect. But if you say to them, well, perhaps this particular idea then is an example of your being mistaken, they will proceed to give you all sorts of personal examples and rationales for why, in fact, it's not an example. We rarely take in and make visceral use of the fact that we know that we're imperfect. Evidence-based veterinary medicine is a process for helping us to do that. Francis Bacon, back at the very, very beginning of the development of science as a methodology, said, "The human understanding, once it has adopted an opinion, draws all things else in to support and agree with it. And even though there may be more ideas or instances or data on the other side of the argument, well, we ignore or neglect these, or we find some excuse to set these things aside so that we can maintain our conclusions." Our natural tendency is to maintain and defend our own beliefs, and unfortunately, we are so good at doing that that we easily ignore or dismiss evidence against our beliefs. Science is a process for explicitly and formally challenging and trying to invalidate hypotheses. And remember, I said before that negative evidence is often more useful than positive evidence because our biases are towards defending our beliefs. Evidence-based medicine allows us at least some compensation for that tendency. Leonardo da Vinci, founder of the Renaissance, brilliant man, said the greatest deception men suffer is from their own opinions. And yet, I suspect that if you had challenged him on a particular point that he was strongly in belief of, you might have found that he was also less likely to accept fallibility in reality than he was in theory. Even going back to the ancient Greeks, before anything that really could be said to be science in the modern sense existed, you find statements acknowledging these general sorts of limitations to human reasoning that bedevil us and for which evidence-based medicine is intended to compensate. When a man finds a conclusion agreeable, he accepts it without argument. When he finds it disagreeable, he will bring against it all the forces of logic and reason. So, evidence-based veterinary medicine is about generating better information, and better information leads to better outcomes. What evidence is there for that? This is a challenging proposition to test. It's difficult to set up a situation in which a clinician will, for example, practice in a non-evidence-based way and ignore scientific evidence and compare that to someone who's using the methods of evidence-based veterinary medicine. There are ethical and practical reasons why such studies aren't going to be done. But there is some evidence that we can use to suggest to us that, in fact, evidence-based veterinary medicine, or evidence-based medicine in the human field at least, does improve the quality of patient care. This is a quote from a systematic review that looked specifically at the implementation of clinical practice guidelines that had been generated through an evidence-based process, and whether or not the implementation of guidelines based on that EBM process led to better outcomes. There is a tendency towards support for the idea that outcomes improve for patients, personnel, or organizations if clinical practice in healthcare is evidence-based and if evidence-based guidelines are used. So they did find in this systematic review that those institutions which adopted evidence-based guidelines did tend to have better outcomes than those which did not, or they had better outcomes after the implementation of these guidelines than before. I also mentioned, you'll recall, that evidence-based medicine is not only about generating evidence, but it's about managing evidence. There's a tremendous amount of published information that veterinarians should be familiar with if they're going to use science to inform their clinical practice. But it is a dramatic increase in the last couple of decades in the amount of this information, and managing it, making effective, efficient use of it can be challenging. Evidence-based medicine helps us with that. It helps us to decide what we need to know to generate specific answerable questions. It helps us with the processes of finding evidence. Evidence-based veterinary medicine is involved in issues like open access to the literature and in developing better systems for making information findable for the clinician. Evidence-based medicine provides processes for making evidence more useful to us. As I mentioned, systematic reviews, critically appraised topics make information that is generated by science more useful to the clinician. So evidence-based veterinary medicine is about managing information as well as about generating it. There's a model for information use that I think unfortunately still lies behind much of the training of veterinarians, the just-in-case model. This says that you take all the information that exists at a given moment in time about health and disease, about your patient's physiology, chemistry, immunology, infectious disease, and you shove all that information into your brain, and then you hang on to it just in case someday something walks into your clinic that needs you to make use of that information. Clearly not a very efficient model for managing the huge amount of information now available about health and disease. Proponents of evidence-based veterinary medicine, in particular Dr. Mark Holmes, who's one of the authors of the Evidence-Based Veterinary Medicine Handbook, suggest an alternative, a just-in-time model. This says that what is important for the veterinarian in clinical practice is not necessarily to know everything, but to be very effective at finding out what they need to know, finding the specific relevant information, and evaluating the limitations and the quality of that information. And to do so in real time as that information is needed. When you have a patient who has a particular disease, and you want to know whether a particular therapy is appropriate or a particular diagnostic test is going to be useful, you should have the skills for turning that into a specific answerable question, finding that information, and deciding whether that information is reliable and how it can be judiciously applied to the care of that particular patient. This just-in-time model of information is built into the process of evidence-based veterinary medicine, and it is much more efficient and easier for the clinician. There is also, from human medicine, some evidence that better information management does lead to better patient outcomes. This is a review looking at the use of various information technologies in hospitals. And in particular, I want to focus on what they call clinical decision support tools. These are tools that allow your doctor to easily access the best current scientific information about a particular disease or therapy in order to help make decisions about the disease or therapy in practice. Hospitals with automated notes and records, order entry, and clinical decision support had fewer complications, lower mortality rates, and lower costs. So there is some evidence that better information management, which is one of the purposes of evidence-based veterinary medicine, can lead to better outcomes. And finally, there's the issue of informed consent. As I mentioned before, being explicit with yourself is important for helping to minimize error in making clinical decisions. Being explicit with your clients is important for them to be able to have the opportunity to make truly informed decisions about patient care, about what they want or do not want to do with their pets. And this is from an article in Academic Medicine looking at the issue of evidence-based medicine and ethics in the human domain. Information about the evidentiary record or lack thereof, that is to say, information about the evidence or lack of evidence behind a particular recommendation, could be viewed as an essential part of the informed consent process, because such information might influence the patient's decision to accept, reject, or negotiate around the physician's advice. So if you say to your client, I think we should use this because I tried it once and it seemed to work, that provides them with information about the uncertainty involved, and that information is different than if you say to them, well, there's a recent systematic review looking at a number of clinical trials which suggest that this is a safe and effective therapy for your pet's problem. And the client may very well make different decisions based on the confidence and reliability in certain recommendations compared to others. So to allow our clients accurate information allows them truly informed consent. So just to review, what is evidence-based veterinary medicine? One way to look at it, it is the formal and explicit application of the philosophy and methods of science to generating understanding and to making decisions in veterinary medicine. So why do we need it? Why do we want to do this? Well, we want to do this to correct our errors. We are prone to all kinds of errors by the nature of how our brains work, and systems which help us to avoid those errors in understanding and in decision making help us to manage our information more effectively and in the long run improve patient care and imply better opportunity for informed consent for. So what's next? Where do we go from here? In order to implement evidence-based veterinary medicine more widely and to take advantage of the potential of this method or approach for improving the quality of our lives as clinicians and also obviously the patient care that we're providing, we need to do several things. We need to overcome some of the myths and misconceptions about evidence-based veterinary medicine, what it is and what it is not, and how it works, and I will be talking about that in another lecture. We need to overcome some of the obstacles to implementing evidence-based medicine. Some of these are ideological and touch upon some of the philosophical preconceptions behind evidence-based medicine. Some of them are practical and logistical and financial, and as a profession, we need to look at the extent to which we want to employ this method and how we go about doing that. And we need to make evidence more useful. The number of systematic reviews and critically appraised topics available to clinicians is certainly growing, but in order to take full advantage of the potential of evidence-based veterinary medicine as an approach, we need to have more useful evidence available. I hope that I've done my job here in explaining a little bit about what evidence-based veterinary medicine is, and also why it's important. I think that the bottom line is that it is a set of tools or techniques based on the basic methods and principles of science, which help us to generate better, more reliable knowledge and make better decisions, and which in the long run will allow us to take better care of our patients, to get better outcomes, and to provide our clients with more honest, open, informed consent. If you're interested in more information, I have a number of other lectures which you can look at here in this YouTube channel. I also would encourage you to look at the websites for the Evidence-Based Veterinary Medicine Association, ebvma.org, as well as for the Center for Evidence-Based Veterinary Medicine at the University of Nottingham.